Welcome to the Seeing is Believing Southeast Asia and Western Pacific Regions webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IAPB. So the theme for this Seeing is Believing webinar is integrating eye health into the health system. And we have some fantastic presentations for you today. Thank you all for attending. I really appreciate you taking the time to join us and be part of our learning community. We've over 25 people registered from 10 countries in the region, which is fantastic. If you'd like to introduce yourself to the group today, you can write your name and which country you are from in the chat box on the side panel. And I see some people have already started doing that, so that's wonderful. I'd like to take this opportunity to say a big thank you to our webinar presenters today. So Yuda Dujo Sapkota is the IAPB Southeast Asia Regional Coordinator. Niming is the Project Manager for China, the Fred Hollows Foundation. And Itfat Khalid Khan is the Senior Program Officer, Sight Savers Pakistan. The agenda I've shared on the screen now. So the agenda for the webinar will be welcome and housekeeping notices from me, Susan. Secondly, introduction to opportunities and challenges of integration of eye health in the Southeast Asia region by Yuda Sapkota. Thirdly, presentation on the integration of eye health in the Fred Hollows Foundation China Seeing is Believing project by Niming. Fourth, presentation on integration of eye health in the Sight Savers Pakistan Seeing is Believing project, Itfat Khalid Khan. And then after the presentations, I will chair a question and answer session. And I aim to wrap up by the end of the hour. Firstly, some housekeeping points. So as I mentioned, I've shared my screen, so you should be able to view my computer screen through the GoToWebinar window. I've forwarded you the PowerPoint presentations in advance, and they're actually attached as handouts to the GoToWebinar. Microphones are muted apart from the speakers, as it just ensures a better quality webinar. And we aim for this session to be quite participatory, and so attendees will have the chance to ask questions during the question and answer session at the end. So if you have any questions for the presenters, please type them in the chat box. And the chat box can be found on the right-hand panel of your screen, and you can post questions either during or after the presentations. And my colleague Saloni Nagpal, the Communication Coordinator for IAPB, is supporting us today with technical issues. So if you have any technical difficulties, for example with sound, you can also send us a message or question in the chat box. And thank you, Saloni, for your support today. And it's a good idea to close down all other web applications, for example, Google, Outlook, Skype, to get a better quality of the call. And if you have headphones, please use them. I find it a bit easier. And I'm recording this webinar and it will be uploaded onto the IAPB website, and I'll send around the link in a few days. Finally, at the end of this webinar, I'll be sending you a survey for your feedback. So the theme of this webinar, as I mentioned, is integrating eye health into the health system. So the presentations today will share successful strategies on how they've integrated eye health into the health system in their Seeing is Believing projects. And we hope that webinar participants will be able to identify strategies which could be used in their projects. I'm now pleased to introduce my colleague, Yuda Doji Sapkota, the IAPB Southeast Asia Regional Coordinator, to give an introduction to some of the challenges and opportunities of integrating eye health into the health system within the Southeast Asia region. So Yuda, over to you.
Thanks, Susan. Hi, everyone. I'm Yuda Sapkota. I'm from Nepal. As Susan mentioned, I'm working for Southeast Asia as IAPB Regional Coordinator. So to talk on the integration thing, the integration has been the major priority of the global eye health. It also been a kind of the priority in the national eye health system. So it is one of the major things, objective or strategy in the WHO Global Action Plan 2014 and 2019, and also it has been highlighted in our Vision 2020, the right to sight. And the integration of the eye health also is still a kind of the challenges for many countries. So it has been also priority for forthcoming document from WHO called World Report on Vision. So, so all this document and the evidences shows that the integration is very important and should be a kind of the part and parcel of the general health system of the country. So that, but everybody knows that it should be prioritized. It should be done, but it's not happening in many countries. That's the issue now. So I talk about the Southeast Asia. I go by country by country with the one statement. For example, the Bhutan. Start with the Bhutan. Bhutan has a complete integration of the eye health in the government healthcare systems. So Bhutan is the country where all the healthcare services is free of cost. It's a government liabilities. So to provide all level of healthcare services. So it includes eye care also. So there are INGO and the NGO, if want to work, they have to work through government. So that is kind of the complete integration. So challenges there is with this complete integration, full integrations, the primary healthcare service or the primary eye care service is very good. Yeah, and then yeah is a full integration in Bhutan, and then but the primary eye care service is very good, but the tertiary level eye care services which is not very satisfactory, as not performing as it should have been done in the case of the Bhutan. I will tell you why later. And the similar thing goes to another country with the full integration in Southeast Asia is Maldives. So Maldives is a complete healthcare system is taken by care by the government with the insurance system. So there is a full integration, but the primary eye care services, the eye care services at the post or the district level, lower grassroots level is not expanded. It's not provided as expected. And in the tertiary level also, there are more private hospitals are contributing than the government hospitals. So the government hospital priority to the eye health is not as much as it should have been. Similar thing, another example is the very good, it used to be very good example of the integration of eye health in the government health is Sri Lanka. Sri Lanka has a very good primary healthcare system, primary eye care system. Since we have found since last few years, it's little bit deteriorating. Is because of the government health priority on eye health, and then there used to be a eye health wing called Vision 2020 in the Ministry of Health that become all of a sudden inactive, and then all the government priority in eye health is now is less, and then not performing as it should have been. The another full integration is Myanmar. So similar thing goes to the Myanmar. There's a government healthcare system did not prioritize enough to the eye care. So there are no INGO are allowed to work freely, independently. So it's every one who want to support in IELTS should go with the government. But there is another monastery health services is there. The INGO are more going through the monastery healthcare and then providing fantastic eye care services and increasing their productivity. And another country is Timor-Leste. Timor-Leste is also the government, but all NGO has to work through the government. So it's a kind of the full integrations. And the best now in the Southeast Asia I have experienced is the Thailand. The Thailand has a very good integration of the eye health into the government healthcare system. But it's not only the central, even the local level government governs the health services there in the village or the district level healthcare services. So the eye care is one of the has got the adequate priority, and then the eye care, primary eye care is well provided in the grassroots level healthcare system also. So another is a DPR. Korea is a kind of the full government does everything, but we don't have much information on that. There are the countries, other countries like Nepal, eye care service is totally being provided by the non-government sector. It's a 95% of eye care service is provided by non-government sector. Government only does the facilitation work. Then we also do have example. And then another is India is a mixed. We can say in the southern part of the India, the non-governmental organization is very active, such as LB Prasad and the Sankar Netralaya, Arvind Eye Care System. They do have the extensive network of eye care services apart from the government healthcare services. Government healthcare services in India is very good at the district up to district level, up to district level, and above that, the tertiary level eye care service is an NGO run kind of eye care services doing better than the government-owned services. And another is Bangladesh is another country is where the both mixed public-private partnership they call it, and then non-governmental sector are also very active along with the government sector. But the non-government sector is productivity in eye health is better than the government sector eye health services. Another is Indonesia, similar to the Bangladesh. The government has says is a full integration, but the private sector contributing a lot in eye health services. So this is goes of the country-wise kind of the things. So in brief, in summary, even though the integration is one of the priorities, everybody says it should be the part and parcel of eye health services. So due to the inadequate priority by the government, so the integration is not functioning as it should have been. And then those countries where full integration is there, the eye care services as not functioning as it should have been. So the main reason is a kind of the government priority. Another reason is a human resource. Very important human resource is ophthalmologist and the mid-level ophthalmic personnel such as optometrist and the ophthalmic technician, ophthalmic assistant, all those cadre. The problem to provide the primary eye care services, this mid-level ophthalmic personnel role are very important. And then in many countries, such as in Bangladesh and in Sri Lanka, and even India and other countries, the mid-level ophthalmic personnel service are not recognized. So the primary and the deputy, it's not possible to depute the ophthalmologist or the other doctors to the primary level eye care services. So one of the challenges here in the Southeast Asia is recognizing the job of mid-level ophthalmic personnel to extend primary eye care. If it is well recognized, then the integration will be the successful. And another thing is we also discussed in the last webinar is kind of the private practice and non-practicing ophthalmologist. In the government, there is a private practicing, mostly majority are private practicing. So the government service productivity are seen bit lower, and that because the timing in the government services is less. So these are the kind of the challenges, and then the situation of the integration. So even the country where the INGOs are very active, non-government sector in eye health is very active. Sustainability of the primary eye care services is very challenges. Therefore, my suggestion would be my experience in this and the suggestion would be, so grassroots level eye care services must be integrated, fully integrated, and government should put adequate resources and the priority. But for the tertiary level eye care services, eye care services needs further priority and then further resources. Only the government resources and government priority will not be enough. So there should be a kind of the synergy and the kind of the collaboration in the tertiary level eye care services. That's what we could see experience in all this country level integrated, half integrated or fully integrated or non-integrated, like Nepal is a eye care services parallel to the healthcare services. Looking at all this eye care service result, output and outcome, those are the challenges and the opportunity in the Southeast Asia. So that I think that my time is over now. Any question I can also answer in the question and answer session. Thanks, Susan.
Thank you, Yuda. That was really interesting. It's not an easy job to do a succinct overview with such a variety of different countries, and I think you did that really interestingly. you know, it really goes to show the sort of different situation of each country, and therefore what the eye care system is and how the integration is working within the countries, and some of the similar challenges of government priorities, human resources, getting it into the primary level. But I think your point about, you know, really integrating into the grassroots is going to be very relevant to the two presentations that we have now. So we'll move on, but definitely I think even I have some questions for you for the question and answer session at the end. So if you do have any, if our listeners, if you have any questions for Yuda, please do start typing them in the chat or the questions section of the chat box, and then we'll come on to those at the end. So thank you so much, Yuda, for that.
Yeah, thanks, Suzanne. Yeah.
Thank you. Right, so for our first formal presentation, let me introduce Niming, who's the project manager for China, the Fred Hollows Foundation, and I'm going to make Niming the presenter. So, right, yes, I want to make Niming the presenter. So we should be able to see your screen in a, we're just waiting to view your screen, Niming. Yes, lovely, thanks. Yes. Okay, so Niming, over to you.
Okay, thank you, Suzanne. Hello, everyone. This is Ming from China program. I'm the project manager of the Fred Hollows Foundation China program. On behalf of our program team to present the eye health integration in our Seeing is Believing Phase 5 comprehensive rural eye care model in Yunnan province. In my presentation, I include three outlines. The first is I will introduce the China local health system and the gaps for eye health, and how we address that gaps in our project, and also what's the outcome of our integration. You can see from this slide, in China, we have the regular primary healthcare training, which is conducted by the local government, but there is no primary eye health in the existing primary health training program. And also in China, we have a basic public health service project provided by the government, which is free. But in that project, only vision acuity check is available in some community health centers, and also the quality is not good enough. And for the diabetic, you know, in China, we have the highest population of diabetic patients, but in our health system, our people with diabetes can be diagnosed in community health centers, and the management of those patients is responsible for endocrinologist department and also from the community health workers. But the endocrinology department don't have enough capacity and knowledge on eye health, on eye complications of diabetic, and also limited communication with the eye department. So there is a gap. And the last one in China, in our schools, we have school health education classes in each schools, which is conducted regularly. But for those schools, teachers or school nurse, they don't have capacity or enough capacity to provide decent eye health education, and they don't have skills to do the eye screening. From those analysis in our Seeing is Believing Phase 5 project in Yunnan, we have three strategies to we want to integrate the eye health into our health system. The first is the training. As I mentioned in the gap session, there is no primary eye health training in our primary health system. So we provide the primary eye health training for our community health workers, which is in China. Most of them are the village doctors, including into their regular primary health trainings by health permission. The training topics including the basic eye health diagnosis and have some minor treatment and eye health education. And also we provide, the project developed the primary eye health training manuals and toolkit, which adopted and applied by the local government. And second, as mentioned in our diabetic patient management, there is a huge gap between the endocrinology department and the eye department. So so the project developed some training curriculum which provide to the inner medicine doctors and endocrinologists. We developed some training manuals which applied during the training, and also regular sharing between eye departments and endocrinology departments happen. So they were sharing the patient and counsel the patient to have a regular eye check in the eye department. And the third, we have regular children eye health training provided for the school nurse and teachers by the local education bureau. We also developed a school eye health manual, which is participatory approach and applied by the local government. And also our school eye health education curriculum is also including into the general health education curriculum in our local education system. And the second strategy is we have several service integration. For example, we have the functioning referral pathway being set up. It's not only between the primary level and the second level, but also between the eye department and the endocrinology department. So before, from our research and our baseline, before maybe 30% endocrinology department patients, they will refer to the eye department. But after the project implementation, there are more than 80% diabetic patients. They referred from the endocrinology department to the eye department to get the regular eye check. And for the screening, we developed several screening protocols. For example, we have the diabetic retinopathy screening protocols in communities and also in endocrinology department, and also adopted by the local partner. And also we have, as I mentioned in the gap session, the local government requested the community health workers to do the visual acuity check, but the quality is not good. And in our project, we developed this kind of eye screening protocol and be integrated into the general health check for local communities. And for schools, after trained, our school nurse or teachers, they can provide a vision acuity check for their students and regularly, so they can have the regular follow-up for their vision acuity changing and inform their the parents. Another service integration, for example, is the health financing. In China, we have the high health medical insurance, including the wild health insurance. And also in China, in China, the medicine of chronic disease in our outpatient department, also including the health insurance, which is just launched in this year. And also after the project, the primary eye health service is available. Before, most of eye patients, they don't go to the primary level clinic to get to seek the treatment or the diagnosis. They directly go to the county hospital, which is the second level. But after we provide the trainings and the local government adopt our training curriculum and the program, they can provide the visual acuity checking medicine for eye conditions. So the local people are willing to seek their primary eye health service in the primary level rather than in the second level, which is a county level. The third integration is about the eye health education. The primary eye health education, we integrate this into our basic public health service project plan, which is the government requests they will do the quarterly conducted. When the health education center develops their annual education plan, they will consider the eye health, which is in China, we have the Eye Care Day, National Care Day in June, and also our World Sight Day in October. So during these 2 months, we will consider integrate our eye health knowledge into the general health education plan. And for the school eye health, we do the school eye health classes and training program was integrated into the routine eye health education. This is not only used for the students, but also the students, but also the teachers will have the lectures for their parents. So this can be linked with their eye health education in their families. And the outcome of our integration is, for example, the local people, especially the elder people, can able to get the basic eye conditions diagnosis and the minor treatment in the local county clinic and the village clinic, which is a people-centered approach. They don't need to go far away, and they can then this can save their cost and time. And the second, we think the eye screening integrated into the community general eye health, and the local people can receive one-stop health check, including eye health and other specialties. And the third is regarding our raising awareness on eye health through multidisciplinary collaborations, for example, endocrinology department, education bureau, eye health education was stressed in the local communities, in intermedicine or endocrinology department, and also in schools. And the schools, children and community people and diabetic patients can regularly refer to eye health unit for refractive error, cataract, and DR diagnosis and treatment through the established pathway. So we think this is successful integration in our eye health into health system and shows very good achievements in our project period and also the out of and post the project period. Thank you. That's all.
Thank you, Niming. That was an excellent presentation. And again, I think the last point that you made about the fact that it's integration during the Seeing is Believing project, but also after the Seeing is Believing project, because you have integrated it. So it means that, the fact that you've got the, your primary eye health manual adopted and applied by the local government, the fact you've strengthened the referral pathways, the fact that the health financing, health insurance is there, and you've managed to get eye health in there. I think it's a real indicator that the fact that you've embedded it within what the government is and the Ministry of Health is doing anyway means that, yes, there are strong indications that the work that you've done will be sustainable after the project as well, which is a real achievement of integration. So thank you, Niming. That was a really great presentation. And then just as a reminder, if you have any questions for Niming, you can please just type them in the chat box or the questions, and I'll answer all of the questions at the end. So thank you, Niming, again. And thirdly, let me introduce Itfaq Khalid Khan, the Senior Programme Officer for Sight Savers Pakistan. And I'm also going to make you the presenter. So I want to make you the presenter. Yes, so we should be able to see your screen in a second. Yes, we can view your screen now. So Itfaq, over to you. We just need to unmute you. Oh, I can unmute you. Yeah. Okay. In fact, we should be able to hear you now.
Okay. Thank you, Susan. Hi, everyone, and welcome again to the webinar. Thank you, Susan, for a brief introduction and also for providing us with this opportunity to share some exciting work we have been doing in Pakistan with the support of Seeing is Believing. This is a great opportunity to share our work at this level. So thank you very much for that. My today's discussion will be focusing on the integration of eye health into primary eye care. Though we have implemented the Seeing is Believing project in different times, different phases, right from phase 2, then 3, then 4, 5, and now phase 5.3, phase 5 tranche 3. But my focus will remain on primarily on phase 3, and then the current phase of seeing is believing. And because this integration is has a long history, so I'll take you through the process that have led us and made Pakistan SiB Pakistan country office to make this integration happen successfully. So I'll be focusing more on the primary, integration of primary eye care into primary healthcare. So now, before moving forward, I think it's important to have a look at the health systems in Pakistan, how it operates, what kind of different levels are there, and what are the governance structure within health system. So we mainly have 3 levels of care within health systems. So there is a tertiary level, where we have tertiary level hospitals taking care of the population of over 1 million people. Then we have a secondary level of care where we mainly have district headquarter hospitals, and these hospitals actually take care of the population of around 1 million. And then we have another level that is the sub-district level. We call it Tehsil headquarter hospitals. But these hospitals are not available in each and every district. These are available only in districts which are bigger in size. Then at primary level, we have rural health centers to cater the needs of around 30 to 50,000 people. Then we have basic health units. That is the first level of care facility to take care of the needs of around 10,000 people. And then at the community level, we have a wonderful workforce of lady health workers. Uh, that is around over 100,000 lady health workers, and each lady health worker is responsible for taking care of the needs of 1,000 households. So these are 3 levels within health system, but my focus for today's discussion will remain with the primary level. We have Lady Health Workers Program, formerly known as National Program for Family Planning and Primary Health Care. And this vertical program was started back in early 90s, and this is very well integrated within the health system. As you can see that they have Federal Program Implementation Unit that is working under the Federal Ministry of Health. Then at provincial level, they have a provincial program implementation unit that is again working under provincial Ministry of Health. Then at district level, they have district program implementation unit that is part of the district health office, and they exist at district level. And then we have another cadre that is called lady health supervisors. These lady health supervisors are basically linked with first level care facility, that is basic health unit in this case. And they are responsible for monitoring work done by lady health workers at household level. And they are also acting as a trainer, and they organize training of lady health workers as a part of their continuous professional development. So this vertical program is very well aligned with the health systems. I'll skip this slide because it's mainly telling us about how WHO look the process of integration and have different strategies. They have mainly 5 strategies of integration of health systems. So I'm just skipping this slide and moving forward. And now we'll discuss about the integration of primary eye care into primary health care. And I'll go into the history because it's very important to understand that how this process initiated, how SiB Pakistan country office realized this need, and what steps and process we have adopted for this integration. So back in 1998, Sight Savers supported National Program for Prevention of Blindness for piloting district comprehensive eye care in one of the districts in federally administrated areas. And that project, DCC project was mainly focusing on strengthening of eye care services at district headquarter level. So that was basically focusing on supply side of the care through deployment of human resources, equipment, technology, upgradation of eye departments and operation theaters and all that. In 2007, this project, this DCC project was a very successful kind of a project, and national program actually scaled up it at the national level, and it was evaluated in 2007. The evaluation of that project noted that at the supply level, the project was has contributed wonderfully while strengthening the eye care services, but there was no mechanism at primary level for disease detection and referral of the patient from primary to secondary level. And the project also noted that in Pakistan we have this workforce of lady health worker, and this workforce can be very kind of useful for strengthening the eye care services at grassroots level. So based on this experience and these findings, Sight Savers Pakistan Country Office developed a project and implemented it from 2008 to 2030 with the support of Seeing is Believing Phase 3, and also with the support of Irish Aid. And this project has made us to do a wonderful job while reviewing the training curriculum of lady health workers. And then under that project we developed a separate detailed module for capacity building of lady health workers, and successfully integrated that training module into the training curriculum of PHC workers. So this integration has helped us to build capacity of lady health workers in their supervisory chain, right from lady health supervisors to district level to provincial level, and training them into primary eye care and referral mechanisms. So with the support of Seeing is Believing Phase 3, Sight Savers were able to train around 52,000 lady health workers across the country in primary eye care and referral mechanism. And with the support of Irish Aid, we were able to train their supervisory chain as well as additional 30,000 lady health workers in primary eye care and referral chain. In 2013, that project was concluded, and in 2014, we conducted a situation analysis with the support of Fred Hollows Foundation Pakistan Country Office and Pakistan Institute of Community Ophthalmology, and that is basically provincial CEC cell in Khyber Pakhtunkhwa province. And the purpose of that situation analysis was to see that how the integration that has happened as a result of Seeing is Believing Phase 3, how is it working, and how the lady health workers are basically screening and referring patients at different facilities, and what are the gaps are there at supply and demand side. So this is basically what we call integration into practice. And we designed a new project that is Seeing is Believing Phase 5 Tranche 3. And under that project, though we also we strengthen the services at secondary level through provision of human resources, refurbishment of eye units and operation theater, development of optical shops and low-vision clinics, and then provision of lens, IOLs and consumables for supporting poor of patient who cannot afford. And the main focus was the main contribution was made by the human resource provided at secondary level. That was mainly 8 optometrists in 4 districts, and due to that trained human resource, there was a major improvement in both quality and quantity of eye care services at district level. But the more exciting work was done at the grassroots level with lady health workers, because we have already integrated that training module into their curriculum, and that is a regular part of their capacity building. So we just organized refresher trainings for 3,000 lady health workers in 4 districts in primary eye care and referral mechanism. We also developed referral slips for trained lady health workers, so that they can use these slips to refer the patients from grassroots level to the secondary healthcare facilities. And through those referral slips, we can track and keep record of the referrals and compliance with these referrals. So these referral slips have 3 copies. When a lady health workers examine a patient at household level and identify with some common eye ailment, she refers that patient to the next level. 1 copy of the slip remains with the lady health worker, and 2 copies goes with the patient. And when that patient report to the health care facility, 1 referral slip is collected by the the hospital team, and 1 remain with the lady health workers. So it was wonderfully done, and lady health workers internalized this concept wonderfully, and they started referring a huge number of patients from primary to secondary level. But we think that this is not the end, but a new beginning, because if you see that huge number of patients were referred during last 27 months, that is over 63,000 patients were referred by lady health workers. However, the compliance of these referrals is critically low, because only 14% of the patient referred actually showed up at hospitals. In the same way, in addition to this, we also trained around 250 medical officers and medical technicians based at first level care facility, that is basic health unit, on the same lines in primary eye care as well as in referral mechanism, so that they can diagnose and refer the eye patient to the relevant health facilities. And that has also worked wonderfully, because they have also referred around over 3,600 patients, and 40% of them have actually showed up to the hospitals. But we think that this is still a challenging area, and we have been facing few challenges in making this integration practically happen on the ground. So the changes we are facing is that there is a very low compliance of patients referred by the lady health workers. And then, because we are counting only those patients who are reporting at partner hospitals, the hospitals which are partner for this particular project, so we are not aware that how many of these patients are actually taking up services at different the facilities other than these partner hospitals. And again, before this project, the National Program for Family Planning, that is Lady Health Workers Program, though the eye care indicators are included into their reporting templates, but and they are reporting on that, but that data is not gender segregated, so and they are only reported with unknown gender. And the assumption with this is that they think that this program was primarily focusing on mother and child health, so they think that they are not catering needs of the male patient. But under this project, we actually established a parallel reporting system in these 4 districts and captured the data shared by them on gender segregated basis, analyzed that, and we shared with them that around 1/3 of the patient referred by lady health workers are male. So they need to rethink and integrate these gender segregated data into their systems. So this is the third problem we have been facing till now. And how are we going to address, what is the way forward, how we are thinking to address these challenges? So that under this project, we are currently commissioning a research study in the project area to explore the reasons of low compliance by lady health workers, and also to know the challenges they face in accessing these services, and why they are not accessing the hospital, despite of the fact that they have problem with their eyes and they are referred by the trained human resources, that is lady health workers. And also we are trying to explore the motivating factors that have motivated those patients who have reported to the hospital for uptake of services. And based on the findings of this study, we will definitely devise a strategy to address these challenges, and that will be completed hopefully by the last quarter of this year. And we are also continuously advocating with program implementation unit at provincial level with the lady health workers program, and asking them, advocating with them, convincing them to integrate, to make changes into their MIS for integration of gender segregated data into their reporting format, as well as consolidate that data at district and provincial level by making it a part of their system. So this was the process we took in Pakistan, along with the support of other stakeholders for this integration. And I think we have done a lot, but it's still, we have a long way to go to make this happen practically at the ground, to increase the outreach, compliance, and eye care services, making them happen at the primary and grassroots level. That's it from my side, and if you have any question, you're more welcome in the answer question session. Yeah.
Thank you, Itfaq. Great picture there at the end. Thank you for that. That's really interesting. Covering of the work that you've done around the lady health workers and the referrals and linking in with the health information system. But what I really appreciate about your presentation is sort of saying that, yes, you've really tried to integrate it within the existing system, but there are still challenges. It's not just a case of we'll integrate it and then everything will be perfect, it will all work out fine. It's that actually there will still be some challenges, on the journey towards kind of full integration. And some of the research that you're going to do around referral uptake, talking to both patients who aren't taking their referral uptake as well as those who are taking, I think will be really interesting. So I can't wait to hear that. And also thank you for your slide on the WHO and their integration points. I think is really relevant for all of us, because of course the WHO World Report on Vision is due to be coming out this year, I think around World Sight Day. And I think a strong element of that is going to be around integrating eye health into health systems. So I think it's really relevant to kind of bring that point out. So thank you so much for that. Now I can see we've got questions coming in thick and fast now. So please, if you have, I can share my screen, or I'll just do, I'll make myself the presenter. Okay. Share my screen. Right, so I'm going to make a start sharing some of the questions that we have. So again, if you do have questions, now is the time. If you can please put them in your question section or the chat section. And what we'll do is I'll start sort of working through the questions as they come in. So first of all, we've actually got a question from Yuda to Itfaq, which is, are the lady health workers getting financial incentives? And secondly, usually their job is heavily loaded with other work such as vaccination, family planning, maternal care, health issues. And in this situation, eye care can be undermined. So please, can you explain your situation? So if you have a bit of a think about that question, and in the meantime, I've got a question for Ni Ming, which is around one of the things that your project did really well was the link between the eye care department and the endocrinology department, obviously with diabetes, you know, as you say, becoming so huge, and the numbers of people with diabetes becoming so huge. So how did you manage to kind of create the link between two departments that hadn't previously really worked together that successfully? So I think if we start with the question to ITFAC around lady health workers, and then Ni Ming, I'll come on to you.
Yeah, are you hearing me?
Yeah, I hear you loud and clear.
Yeah, thank you very much. Thank you, Uda, for the question. Yeah, you are very right, because when this program was started, so the focus was on mother and child health, basically. But later on, so many other subjects were included into the responsibility of lady health workers. So yes, they are quite overburdened, and yes, it's been a challenge to make eye health a priority for them. But since we are doing it, making changes within the system, so what we did, that we made it a part and parcel of their training curriculum, and then we trained them on the referral mechanism and made it a part of their reporting system. So till now, I mean, they are doing very good with this, because it is part of their system, because they have to visit a household on regular basis. So once they examine the patient for any other disease, they can also ask them if they have any eye problem. So if they encounter any patient, they just record it into their system and examine him or her and refer them to the relevant facilities. So we are doing it well, because we have integrated this into their system. And again, it's very difficult to say that how it will go in the longer run, and that's why we are actually making efforts and advocating with the program implementation unit to make changes into their MIS and make it very explicit, including eye indicators and making them gender segregated, so that this process will not stop in the future when the project support will not be there. Second part of your question was around the financial benefits. So yes, lady health workers are basically government employees. So this program, when it was started, it was donor funded. So later on, it was taken up by the government. For a number of years, lady health workers are on temporary contract basis, contracting employees, but now they are permanent employees of the government, and they are getting salaries from the government. We only support them when we engage them, I mean, for the trainings. So the program implementation unit, they request us that they don't have any allocation for their honorarium or travel cost. So we support them for that. We supported them for that under this project. But they are permanent government employees, and government is supporting their salaries and other benefits. Yeah.
Thank you for that, ITFAC. Okay, Ni Ming, over to the question about the integrating or the link between the eye department and the endocrinology department.
Yes, thank you, Susan. I think there are several factors to make us to have these good achievements. I think the first is we give very good trainings for our endocrinology department doctors. And also in our project, we developed the training curriculum, which is not only provides the knowledge training on eye complications caused by the diabetic, but also we give them some tools like the standardized referral sheet and also the standard information sheet for the doctors. For example, in that sheet we list what kind of diabetic need to refer how frequently, and what's the key information the endocrinologist endocrinologists need to communicate with the patient regarding eye complications. I think this is one of the factors we can achieve good. And second is, this is between two departments in the hospital. Very key, we think is very key goal support from the hospital management. For example, the deputy president or president of this hospital, they can help us to coordinate between two between two departments. And third is, we think the good data system management. For example, in one hour project hospital, the doctors from endocrinology department, they can give the electronic ticket to the to the diabetes patient. The patient can get the free check in using that ticket in the eye department. So we think this is quite good. This is convenient and also very good clear instruction in the endocrinology department and the eye department to show where the endocrinology department is, so they can very easy to find the way, and also we turn the green light for the people who referred from the endocrinology department to eye department. And the fourth is we linked the chronic disease management in the community. So in the community for the community health workers, we also ask them to provide this health education to the diabetes patients, so they can increase the awareness, which can also contribute for the endocrinology department referral to the eye department. And the fifth is, I think, the association collaboration between between ophthalmologists and endocrinology department, because some standards or some guidelines published by the association. So if from the academic level they can have this awareness of the protocol, is very convenient or useful for us to promote in the county level or lower level. And also the last one is, we think it's not only the endocrinology department can refer the patient to eye department, but also eye department can refer back the diabetes patient to endocrinology department. For example, some people have cataract, but they don't know their blood sugar status. Before the surgery, they need to do the blood sugar test, so they found they are diabetic or they are high blood sugar. So the eye department will refer back to the endocrinology department, which is two-way referral, which is a win-win situation. Yeah, I think that's all for our experience. Thank you.
Thanks, Niming. Yes, and I think that's having that relationship, that two-way relationship, so that both departments are benefiting from it, is, I think, and see the value is really important as well. So thank you so much for that. Okay, good. We've got so just a reminder to people, we're just slightly over 10 o'clock, but I think we can maybe extend maybe 10 minutes or so. So if you do have a question, please do ask, because we've got a few questions coming in now. So don't be shy, just send your question if you have one, and I'll ask it to our panelists. And we've got a question from An Pham Kok from the Fred Hollows Foundation Vietnam. Thank you, Anne. So he said, and this is to all of our panelists, including Yuda, I think, which is, do we have any tool to assess the level or how well eye health is integrated into health systems? And this is a nice question, because I think one of the things that came out from both presentations was that they both Niming and IPFAC had spent time at the beginning of the project really understanding the health system and doing a health system analysis and looking for those gaps for eye health, and then being able to then, to look at ways to integrate it. So this question, if we start with Yuda and then Niming and then IPFAC, so do you have any tools to assess the level of how well eye health is integrated into the eye health system? Yes.
Yes, yeah, Susan.
Please, yes.
First of all, it's me, Yuda here. First of all, I would like to mention mentioned that there is no standard kind of the model or the tool will work for all country, because for the integration of the iHealth into the health system, because it also depends on the type of the health system exist in the country, because some country has a health system is completely free, and some system has a paid by insurance, and some in some country the health system is mainly out of pocket expenses. So it depends. The integration model also differs on this country's health situations. And then just to answer the question specifically, the integration means the eye care should be part and parcel of the healthcare system with the WHO. It's given the point in the five points. So I think I don't know, is it there is as such the tools just to measure the level of integration. That means the integration standard tool is developed on that. I don't think I haven't seen. So mainly the integration means when the patient in eye care service should not be the parallel to the healthcare system. It should be a part and parcel from the grassroots level to tertiary level. And in the tertiary level, eye care should have some kind of the independency. I mean, to develop further, because a lot of subspecialty will not be prioritized by the government system. Those kind of the systems should work. I think. Thanks. Over to Susan.
Thank you for that, Yuda. And you're right that the situations within countries can be so varied. It can be sort of tricky to have a sort of a one-stop shop. But Niming, how about for you? When you did your assessment, was there a specific tool you used, or were you using Fred Hollows Foundation tools? How did you do it for you?
Yeah. In our Fred Hollows Foundation, we have a toolkit for situation analysis, which including the policy analysis, stakeholder analysis, system analysis capacity for our hospital partners analysis. So we use that tool to assess our current situation. And also when we do this, we will have some focus group with different stakeholders to understand the real situation, not from the literature review, but also from the real situation. So after that, we will wrap up and came up with some strategy to address the gaps.
Great, thank you, Niming. And Itfak, how about for you when you did your assessment at the beginning of the project? Sorry, you're unmuted now. Sorry, Itfak.
Okay, thank you very much. I just said that it's really a good question. And I'll agree with Yoda that there is, I mean, I didn't come across any standard tool for this. However, we can have a few indicators if we talk about the primary level. So we can have a few indicators to gauge that how good that integration is, and these indicators can include the effectiveness of referral chain that is developed from primary to the upper levels, and then the patient are being referred, and the compliance rate of the patient, because the ultimate purpose of this integration is to benefit the end user, that is the patient, that is community. So if the patients are referred patients are accessing eye care services or not, we can have an indicator on this, and then we can do this through patient surveys if they are satisfied with the eye care services and referral chain and all that at primary level to secondary level. So we can have few indicators and we can measure it and see that how well this integration is become a part of the system instead of working as a parallel system. So this is the key, I think. Yes, Susan.
Thank you. Yes, that's the thing, isn't it? It's what are you measuring? because that's one of the key things, isn't it? When it's measured, it's people kind of take note of it. And the only other tool that I've come across myself that I've seen other Seeing is Believing projects use is the one that I'm sharing on screen, which is the WHO Eye Care Service Assessment Tool. And that I've seen projects have used that basically to, well, here it says it's sort of the tool that provides guidance for assessing the status and functionality of a country's eye care services on the basis of the 6 areas of the WHO framework for strengthening health systems. So that could be something that you could consider using just to, for each of the different areas. It takes you through, leadership and governance, eye care financing, workforce, etc. So you can have a look at the gaps within the eye health system within the general health system. So that could be something that also, taking all the other points into consideration, that also could be something that you might want to kind of consider. Okay, so it's just sort of final chance to ask any questions to any of our organisers. We don't have many coming in, so what I think I might do is sort of round it up. But thank you ever so much to our, oh, and thank you, Anne. That's for just thanking everyone for their responses to his question. So I think it's been a really interesting session today, and I think, as Yuda said at the very beginning, all the context of our different Seeing is Believing projects across these regions is quite different, but some of the challenges of within integrating eye health into the healthcare system, particularly at the grassroots level, are similar, and I think these projects hopefully have given some ideas around different ways it can be done, thinking about, are you integrating the data into the Ministry of Health data system? Are you building up relationships outside of the eye health sector with the diabetes department, with the education department? The point that Yuda made at the very beginning, that some of those countries, they do have eye health, it is a priority in the government, and the work that ITFAC's doing in Pakistan around, trying to push the kind of integrating the data into the health information system is really important in terms of lobbying the government and showing them the need, that there is a problem here, and it should be prioritized. And the work that both Fred Hollows China and Sight Service Pakistan have been doing around strengthening those referral pathways, and seeing that are people travelling up through the system, and then the research that that Sight Service Pakistan are going to do around people not kind of taking up referrals, I'm really looking forward to receiving, because that I think will be really interesting. So some really good ideas there, and hopefully they're ideas that you think will be relevant to your situations as well, and that you can sort of think about how to integrate them within your projects as well, and particularly thinking around the point that ITFAC made around the WHO points of integration, and then looking out for the World Report on Vision that will be coming out towards the end of the year, I think will be really interesting. And if you've also got any points yourselves to share around how you've done integration of eye health within the healthcare system, please do share them with the Seeing is Believing newsletters. I think the next one, the one after, will have integration as a topic, so we do want your examples as well, please. So finally, let me end by thanking our presenters, Yuda, Niming and ITFAC, for their comprehensive presentations and responses to all our questions. Thank you, Saloni, for all the technical support. And thank you for everyone who's participated. I really appreciate you all taking the time to be part of our Seeing is Believing learning community. And I just have one final favour. I'm now going to email you all the Seeing is Believing webinar survey. If you could please just take 5 minutes to complete it, as your support for these webinars makes them possible, and your feedback helps us to constantly improve them. So thank you again, and I look forward to seeing you all at future Seeing is Believing webinars. Thank you, everybody.
Yeah, thanks, Susan. Thanks, Atik. Thanks, me. Thanks, everybody.
Yeah, thanks, Susan, and thank everybody for the participation and questions.
Thank you for your time.
Thank you, everyone. Bye.
Thanks, everyone.
Yeah, thanks
Bye then.